Welcome to the American Enterprise Institute. Thanks for joining us this afternoon. I know that everybody is excited for cocktail hour, but we are going to have a great discussion. It's great to see the room filled. I am Brian Miller. I'm a non-resident fellow here at the American Enterprise Institute. I'm also an associate professor of medicine and business at Hopkins, where I practice as a hospitalist. I should also note that my opinions are my own and do not necessarily represent those of any of my employers or affiliations. I'm very excited today to spend some time talking about health policy under the new administration. The Trump administration during the first term expanded the Overton window for health policy and is continuing to do so. I'm really grateful to have my good friend Eric Hargan here, who has been in and out of administrations for the past 20 years in Washington, even back in the Bush administration, and then most recently served as Deputy Secretary of Health and Human Services during the first Trump administration. So welcome to AEI, Eric.
Thank you. Thanks. Good to be here.
I know that with all the international strife that's going on with taxes and trade, we're facing a resurgent China right now.
Right.
And China is actually attempting to dominate the global life sciences product development chain and also manufacturing. And foreign policy is shifting, and we're going more towards the spheres of influence model, with China, of course, trying to dominate both in its sphere and both globally in life sciences. So how do you think America can strive for dominance in pharmaceutical product development, purchasing, and also production?
Yeah. Well, I think, there is a way in which the U.S. is still in the catbird seat in the pharmaceutical area. American companies still dominate the area in terms of like brand name pharmaceuticals worldwide. But China has rapidly caught up to the United States in a number of areas. Some of them are natural areas of strength for China, being able to produce the raw materials for pharmaceuticals, whether it's excipients or active pharmaceutical ingredients. China just does a tremendous job in that area in terms of being able to produce at very low cost. In fact, the United States supply chain, as we saw in COVID, had become very, very dependent on Chinese suppliers for basics of things. Whereas the United States was, having been there at HHS during there and on the board of Operation Warp Speed, you saw what was happening, right? Which is that the US could produce a lot of great high-end devices or pharmaceuticals, could invent a lot of things. But if you had a tremendous, say, COVID test machine that could be produced in the United States like that, but you don't have any nasal swabs to use. Where are the nasal swabs? That's a problem, right? You can have very high-end things made in the United States very well, and you don't have any cotton swabs to use. Where are they coming from? They're coming in C-130s from China. They're being sent, we're going over there in planes to bring them over, and having a lot of tense discussions about it. To be honest, with the government about bringing those over here. They needed them themselves. These are big problems that kind of surfaced in COVID. They'd surfaced before when I was there under Bush. These things happened before. There were attempts to rectify it. Those attempts didn't turn out as well as anybody could have wanted. We didn't really have those same things that we had planned on when we came back in Trump 1. But there are a lot of ways in which China has done a tremendous job. Their clinical trial protocols are now kind of state of the art. Are they, I would say the FDA probably would say, well, they're not as safe, we're still the gold standard. But they're able to develop quickly and effectively now in a way that they could not have done so 10 years ago. So there's a way in which very thematic stuff that's been done in regulatory science in China has enabled them to develop credibly. Whereas like, say when I went to China in 2006, first US-China strategic economic dialogue, I met with, at the time, the head of the Chinese FDA and their version of pharma. And they said, well, we want you to bring all the Chinese drugs over to the United States. And I said, well, you can't sort of bring all of them over. And they said, well, no, they're safe. And I said, well, you've got to go through clinical trials in the United States. And the head of their pharma said, we've gone through 5,000 years of clinical trials, right? Having a very different idea about what clinical trials even did in there and not interested really in the US model. Well, that's 20 years ago. That's definitely not the case now in terms of the level of sophistication, in terms of being able to access data, being able to run clinical trials in an effective way. Catching up on that, in some sense, surpassing the United States, at least in the ability to produce speedy data, is real. And it's a serious concern that the United States needs to take, in spite of the fact that right now we are sitting in a fairly good position in terms of our existing companies, but they're under pressure.
I was going to say, so for biotech, pharmaceutical product development, medical device innovation leadership, we actually stole that from the EU 20, 30, 40 years ago.
Yeah, I mean, to some extent, the EU's been doing a pretty good job on biotech too, like in the last few years, in terms of like biosimilars and is sort of the areas of so-called generic biologics. Sorry, anybody who's here from bio will be very unhappy with that phrase, but the biosimilars area, they've definitely done a good job. And again, in some sense, it's the regulatory science. It's the ability to do the regulatory side has been fairly good. The EU has been creeping up on the US, but you're right. I mean, if you the early discussions 20 years ago, 15 years ago, definitely the EU has been pretty far behind, and they used to dominate, obviously. 100 years ago, there wasn't any question about it. Even today, you look at some of the giants, Bayer, right? Everybody has their aspirin, but now you've got US companies that dominate the area of sort of cutting edge. But there are plenty of companies, Novo Nordisk with Ozempic. The EU, the Europeans definitely, when they step out on it, they're capable of producing revolutionary technologies. And so don't sleep on Europe for sure.
So you see the potential for us to maintain life sciences and biomedical innovation dominance over the next 20 years.
For sure, we could, but that's going to take an investment in some of the fundamentals that the United States had articulated and had done a very good job on. And right now you see the US looking, thank goodness, to things like AI and how to restructure, how to deal with data. I would say the FDA has not really slept on this in a lot of ways. They've been doing, they've had an idea about overcoming some of what they will refer to as old-fashioned notions of data. And the US doesn't have the EU's quite as firm an idea about privacy that hurts the EU in terms of being able to access healthcare data and to use it in a certain way. And I think the FDA is at least starting to articulate a vision under Commissioner McCary and others that is starting to sort of look pretty far forward in what they can accept in terms of safety and efficacy signals, in terms of new products, and how they can use real-world data and absorb data from all different places instead of just relying on these kind of like hammer through tens of thousands of people into a clinical trial. And oh, by the way, we didn't get that question just right, so add another few tens of thousands of people onto that clinical trial and do it all over again, essentially. That kind of attitude leads to hugely costly trials, costly in terms of both time and money, and access to the drugs that could be saving lives right now or ameliorating disease states right now. So I think the good thing is that Americans are not against risk in risk reward, and we have not adopted the precautionary principle in this country. We're definitely able to, culturally are capable of looking, well, I'll take a little risk for a reward. I can evaluate that. So we haven't sort of tumbled in a direction that I'd say I was worried about 15 years ago.
And then I was going to say, what are your thoughts about sort of onshoring and nearshoring? I mean, I look at this as a critical actual push for national security, looking at the rising tensions with China over the past several years, that this is a positive push to increase national security for essential medicines and also restore jobs and skills and training and manufacturing, well-paid jobs with technical skills and engineering back onto the U.S. soil.
Sure, I would say it's national security, definitely. We saw that definitely during COVID. That was an issue in many things, that we had done stuff that was sort of logical in terms of just-in-time delivery and outsourcing to the lowest cost source, that hurt us in the middle of a crisis. And I think you're right in the sense that developing jobs, obviously, it helps the economy. Life sciences and healthcare in general is a huge element of the US economy, bigger than any other country, obviously. And then on top of it, I think it brings a culture of like the whole
Innovation
culture of
across-
innovation all the way down the chain. In other words, like I think it allows a closer look, especially in our culture that does prize innovation, that really does want to look at these things. We're not culturally sort of backwards in terms of going, let's fix this, let's try something new, let's innovate. That's not a real problem for us as a country. And I think bringing more of those elements into the whole chain of the life sciences, I think it can't do us any harm whatsoever.
And it actually fits with the focus in academia of actually moving towards STEM education, right? Whether it's biologic fill finish, whether it's clinical trials, whether it's preclinical work, whatever it is, moving some of that back onto American shores, I think will be great for the economy, and policy pushing in that way, it sounds like you think is going to happen over the next couple of years.
Yeah, I think, and I think, and there's probably a helpful feedback loop. There's probably a virtuous circle between pushing on STEM education, having more availability of those kind of jobs and opportunities inside the country, that leading to more emphasis on these things because there's more need for them as time goes on.
So I also want to turn to MAHA. And so I'm an internist, everyone knows I'm an internist, but I'm also actually a board certified public health and preventive medicine physician. We're 0.5% of the workforce. So when I see a focus on prevention, I get excited.
Yep.
My question, though, is more tactical, which is how do we operationalize the preventive care promise behind MAHA?
Yeah,
which is not an easy question.
No, it's not. I mean, there's a reason why it hasn't been done yet, right? It's not just because we forgot. In fact, like if people hear what the sort of fundamentals of MAHA or RFK or his group of people, when you get through all of the stuff that surrounds it, right? You get down to fundamentals, which is they want to address obesity, metabolic syndrome, heart disease, hypertension, diabetes, right? And when you boil it down, eat better, exercise more, like de-stress, sleep more, get out in the fresh air and the sunshine. Uh-oh, what a surprise. We never heard of that. The problem is how do you turn that into a real focus, especially early enough in the cycle, because we have such a decentralized healthcare system in the United States. It's remarkably decentralized, and there are positives to that. It's not all negative to have a decentralized system. Speaking as an old M&A lawyer, I don't want to get into it, but centralization does some good things, does some bad things. Decentralization does some good things, does some bad things. You don't get to have them all. It's not all good to have a central tower that directs everything in a central system. There are things that you leave behind. You leave behind innovation, you leave behind personalization, you leave behind a lot of things when you centralize everything.
So,
and so MAHA, the idea, if the government has a role here, and it obviously gets the patients, unfortunately, it gets patients when they're so far down the track normally. The normal Medicare patient is 65, right? Disabled as well, but sometimes, but the 65-year-old. So you're already often, it's baked in the cake. By the time the government gets to the point where MAHA, as conceived in HHS and the Medicare program, it's already like, okay, where is the patient already? Many times they're already far down the road on these kinds of things that could have been prevented, right?
So
yeah.
a question along that. So I said I'm an internist, so people, drugs, surgeries, procedures, I'm familiar with all that, but by putting my public health hat on, again, and thinking about preventive care, do you think that there is an opportunity to partner, for HHS to partner with other departments and other agencies? For example, it's hard to exercise if there's a lot of crime and you're worried about getting shot when you go outside. It's hard if you don't have transit and you can only get around by a car. So do you think that there are opportunities for HHS to partner with other parts of government and the private sector?
Well, I mean, I think there's probably two things there. There are other parts of other departments, the VA, there are even agencies inside HHS that deal, like Indian Health Service, that deal with non-senior populations. There's elements there. I think, but when you're talking about those things, the sort of what we used to, maybe we call them again, the social determinants of health. Like, what do you do about those things, right? Whether it's crime, family structure, organization, jobs, housing, all that stuff, transportation you mentioned, food. I mean, that was a social determinants of health. I'd say in Trump 1, we weren't afraid of that. In fact, I conducted the listening sessions for the SDOH project there. The difficulty we had was which ones work and which ones don't, and to what extent do they, and to what extent don't they. Each one of them has an entire ecosystem of advocates that say, this is it. This is the thing that's going to solve all your problems. And it's hard to, from a governmental point of view, identify which of these things and to what extent are affecting the healthcare and driving people away from the preventative and driving them away from being able to focus on those parts of their lives, right? So I basically, I hate to say it, I just sort of let it alone after a while, right? I did my listening sessions as I was asked to do, and I was like, it just seemed like a buzzing beehive by the time I was done with it, to be honest. Was like, everybody had an idea. Everybody had a good idea. They all seemed very convincing about it. And I wasn't gonna say, that's totally wrong. But to what proportion? No, nobody had, and we didn't have time, frankly. COVID hit not long after that, and that sort of knocked us out of the field in terms of like developing strategic thinking about the overall healthcare system and what causes problems for people in the United States. But I would say it's not a bad idea to go back into that. And I think MAHA is not a bad route to open that discussion up again. I think it's opening the door to that, and it's widely applauded.
And it expands that Overton window. I think about transportation
100%.
As an example, and I want to shift to financing and delivery in a second, but I think about transportation, what percentage of our audience got here via walking to the metro and getting here via the metro versus I grew up in suburbia where there was no mass transit. With a focus on infrastructure and health, there is an opportunity to expand that Overton window and think differently.
Well, and it goes beyond that. I mean, you look at even family structure plus transportation. Like, mom's sick, mom can't get to the things. One of the kids has to have time, day off from work, drive mom to the clinic, go and drive her back. Like those kind of things, that's transportation too. But it's mixed in with family structure, with a whole bunch of things. Geography, do you have to go over the mountain? Right? How long does it take you to get there? Like, what time of year is it? It gets complicated. Is there a blizzard? Is there a flood? Those things get very complicated very quickly. And you sit there, I sat there kind of like the end of the funnel, right? Listening to everyone. And yet at some point you go, I don't know what we're gonna do. We're gonna you have to sand that down in a way. The government can be the right convener for those kind of discussions. And you hope MAHA, if it persists and keeps going, could definitely add those kind of questions. And I think thematically pretty easily. It's easier to do that in MAHA than it is in Cancer Moonshot or whatever other
which is more narrowly
slogan.
focused.
Yeah, which is more, I mean, so it's opened the door to that. And I think prevention is definitely right in the wheelhouse of that particular movement.
So I have one question before we take a few minutes to get questions from the audience. And I did not want to neglect healthcare financing and delivery, given that I trained in hospitals, worked in hospitals.
Yep.
Everything that patients get in the US is largely paid for by insurance. Knowing that managed care in both Medicaid and also Medicare has promoted some vertical integration of payers and providers. There are a lot of large integrated health systems, Kaiser, Geisinger, Intermountain, and some smaller ones too. With all that's going on, how do you think integrated delivery systems can best engage in the current policy debate? Well,
I think it's difficult, right? I mean, you identified three that are like, they're very similar. They're like a family, right? To me, Intermountain and Kaiser and Geisinger, right? Because they're all like come inside the system. They're not like just show up at the hospital and I'll go to the next thing and clinic, everything's decentralized. Those are ones that really focus on bringing everybody in and doing a lot of prevention and things like that. How do they engage in the system? Right now, we're in an unusual point. We're at an inflection point where I think systems like those, the integrated providers, can they develop the kind of models inside themselves and data to show the success of these things? The knock on prevention has always been, and that too. It's the same thing with diagnostics. People go like, well, I'm eventually gonna have to pay for this ridiculously expensive surgery, and that too. Is prevention really going to get there? Is the old saw, an ounce of prevention is worth a pound of cure? Is it really, right? Is it really? And to be able to show that, we haven't been able to do that very well in the richest and most lavishly funded healthcare system in the world, easily the United States, right? And the largest place where you could show those things, right? A place that's not data heavy. It's pretty data heavy, and we're pretty good at capturing it, but it's all over the place. How do you show the journey of somebody through the different parts of the system and be able to show that it actually works, or that one of these clever ideas works? I think a system like that, or these integrated systems, as they developed under pressure, whether it's from the ACA or whether it's under just general pressure, competition inside the US, different elements, can they actually thematically figure out what works and be able to turn that into something that's replicable, that's trustable, and that they can provide to everyone? Say, here's actually what works, right? Or here's a set of things that actually work, and that they can, but that's been the price. It's always foundered on the idea that they can never follow the patients for a long enough period of time, right? They never have them long enough. Or when you do have them long enough, like in Medicare, it's sort of like, well, right? You're already dealing with issues that have developed over a lifetime. So I think that's an interesting idea. If you could find a system that had the ability that was sticky with the patients, and could actually get something that's pretty data rich, that was able to follow this over not just a short period of time, but over a longer period of time, without it falling into the problems of a centralized system. It's not like the centralized systems have produced any real humdingers of solutions either, right? I mean, people are like, oh, it'd be great if you had the NHS or whatever. Again, no knock on the Brits, but like, I don't know that their prevention is working that well, right? I don't see the Brits getting like thinner by the year or anything like that. Quite the opposite, right? They're catching up to us. Well, why, right? And that's a centralized system. Can't they do something about it? It's harder than you think, right?
I said I strive to grow emotionally rather than in size, but that doesn't tend to happen.
It's difficult.
So we'll spend, before we switch to the panel, I thought we'd take questions from the audience or online.
Yeah.
There'll be a wandering mic.
Yeah. Or maybe Ozempic will save us all.
You mentioned China having adopted a lot of our testing standards. During COVID, there was a big issue as to whether we could trust China's laboratory results.
100%.
Is that still an issue? And with budget cuts here, are we into a similar problem?
Okay. Have budget cuts really happened? Okay. Like, ask somebody who's dealing with like what's happening with Doge. Has it really happened yet? Some cases, yes, in some cases, no. In some cases, let's wait and find out what happens with Congress, the rescissions bill, the Impoundment Control Act, what's going to happen between the administration and Congress in the next few months, right? I mean, you see already there's a lot of pushback on this, what's going on with the budget. We don't really know where the chips are going to fall. If you've been around town, presidents propose budgets all the time. Congress does whatever it does in its crazy way. So let's put that off to one side. I don't think our lab systems are going to go down in any real way. China's have come up, that's for sure. And I'm not going to just say they're labs. Let's leave that to one side. Their protocols, their ability to kind of start analyzing things in the pharmaceutical area is getting better and better. Their ability to conduct clinical trials. So leaving off to the side of like, do you want to trust their clinical labs results or their CBCs? I don't know. But is it getting better and better? Is their product getting better? Yes, it is. Their data product is getting better. Like their ability, their they're not as far behind the US as they were 10 years ago. It is nowhere near. And personally, I thought, well, as long as they're communist, it's not going to happen. Because I was like, they're making fake reports all the time, I think, to please whoever's above them, which is a problem, right? But their companies are subject to a lot of the same discipline in the world market as US companies are and European companies are. And I think they're responding to that, and the government, for whatever reason, is responding to that by adopting better and better systems and being able to be a little bit more free than they were. That's my outside analysis of what's going on there, right? Never been in the Chinese government, so I don't really know. But US government only.
I think we have time for one more question. Yes.
Thank you so much. You mentioned the fact that the FDA really relies upon the gold standard of data, and they won't accept other sources. To what extent do we really need then a companion system whereby you could have other agencies or outside groups that would approve drugs or at least give their blessing, similar to what the U.S. Pharmacopoeia did in the 1950s? Would that drive more innovation in the United States?
Yeah, I mean, I think it's going to be difficult for the FDA, sort of legally speaking, to adopt a lot of that, right? I mean, there's a push, they're stuck in many ways by public expectation. There's a huge part of the public that pushes for 100% risk-free. Nothing may ever happen. Nothing can ever happen to me. There can never be any errors. I can never have a side effect. There really are. There's a lot of people that have unrealistic expectations about everything, right? And they're a big part of the public. It's not nothing, okay? They've got to balance that with people who are sick, who desperately need access to drugs right now and are willing to take a shot, okay, at anything, right? The old Abigail Alliance people, the right to try side of things. So they're in the middle in this sort of risk-reward continuum. What do they do about outside groups that want to come in? Now, they already have them, right? They get material from pharmaceutical companies, they get all kinds of data, comes into them from outside. They do some testing themselves, but a lot of it is them absorbing and analyzing what's given to them by companies looking for approvals and clearances, right? So they're not bad at analyzing disparate data sources. The question is, I think they're going to be grappling with next, I think it's going to be interesting to see, is to what extent are they going to be able to look at more models, like AI? Are they going to be able to look at different kinds of mileposts and abilities to kind of see what does this clinical trial really establish, and how do I match it with these other pots of data? Can I take this white paper that was by a reputable source and sort of mash that into my analysis and mash all these other pots of data that I can now get access to, and sort of start creating a lot of information from a lot of different places and be able to trust it, to be able to clean it, trust it, analyze it to where they can make the decisions they need to make in kind of the risk-reward way to decide whether something's safe and efficacious for their ultimate standard. I said, but I'd say that AI, just generally the data revolution over the last few years, has kind of opened their eyes, and they were already thinking about these things. I mean, Trump won for sure. These things were already being set on foot, to be chilled by COVID, of course, but then they're reanimating that now. We went down that course. We had a whole thing, AI for AI, artificial intelligence for American industry, and Trump won. And a big portion of that was dealing with pharma. So they were already thinking this through, but now it's gotten, I think, put on wheels by the current commissioner and their crew. And we'll just have to see what's going to be acceptable, because there's going to be a lot of talk across the entire sector about what's acceptable here, given that there is a poll of public acceptance and desire on each end that they have to grapple with. And it's not just their own, they're kind of wobbling between that kind of protect and promote public health. The two aims of the agency overtly are to protect and promote public health, and they're two different things. They seem they're similar. They almost sound like the same word, but they're not, right? The protection people and the promotion people are different.
Well, thank you for joining us.
Sure.
Round of applause for former Deputy Secretary Eric Hogan.
Absolutely.
We'll adjourn for about 2 minutes and reconvene for the panel.
Yeah.
Thank you.
Sure.
I had extra questions because I figured it was fun. We could hit the China. If you have time to stay, great. If you have to go, it's totally okay. Literally. At the end. I'm at the end. I got more water. We'll start with introduction. Thank you. Welcome back. We have a esteemed panel of colleagues here. I thought that I would do some brief introductions and also give them a moment or two to say some opening thoughts. First, we have my colleague, Dr. Lisa Grabert, who is a visiting research professor at Marquette in the College of Nursing. She worked at the American Hospital Association, the Centers for Medicare and Medicaid Services, and also Ways and Means. Next to her, we have Dr. Gowda, who is a pulmonary and critical care fellow at Emory University and an expert in CDC and public health infrastructure. And then lastly, we have my colleague, Dr. Anthony DiGiorgio, who's an assistant professor of neurosurgery at UCSF and is an expert in 340B and Medicaid policy, in particular Medicaid managed care. And I'm now excited thinking about this and do want to ask you a question and change our order about 340B, because as I said, the administration has shown that that Overton window is going wide in health policy. We're thinking about things totally differently, whether it's manufacturing regulation, whether it's payment policy, and 340B is part of that. And it seems like the administration has shown that it's willing to do things that no prior administration has. So what would you say that the ideal state of 340B looks like?
That's a great question. Thank you, Brian. And of course, I have to add my own disclaimer that none of my views represent those of my affiliations or institutions. I think the 340B is a great conversation because right now it acts as a subsidy program for hospitals. It's essentially an open discount program that the hospitals have turned into a subsidy stream, and it rewards the hospitals that see a high percentage, a high proportion of well-insured patients. The more well-insured patients they see, the higher their subsidy ends up being. So I think the ideal 340B state is to accept that it is a subsidy stream, but make it a capped safety net grant that follows the patient, that follows the low-income patient, and rewards institutions that open their clinic doors to low-income patients. We all know it's an open secret in healthcare that a lot of clinics throttle low-income clinic spots. The 340B currently uses an inpatient metric to qualify for 340B. For an outpatient drug program, again, doesn't really make sense. So instead, if we turn it into a safety net grant that follows the patient, the individual patient can direct those funds and take it to whatever clinic opens their doors for it, be it independent physician practices, be it nonprofit, for-profit hospitals. As long as those clinics, those outpatient clinics, are opening their doors for these safety net patients, then that grant money can go towards them. So it really would shift that axis. So instead of rewarding institutions for seeing a lot of well-insured patients, opening new clinics and child sites in well-insured areas, wealthy areas, instead taking it and making sure that the clinics are rewarded for opening their doors to low-income individuals.
So to be clear, you think that the 340B program should not discriminate against independent private physician practice or tax-paying hospitals and health systems?
That's correct. Right now, it acts as a thumb on the scale for these large non-for-profit entities.
And so if you and Lisa, I'm curious, what actions do you think Congress could or should take to push the ball forward on 340B?
I think, again, reimagining it, and I think having some more, if they want to tinker with the program, defining patient better, defining transparency better. But I would be, like you said, shifting the Overton window, going for large-scale change to reimagine what the program actually looks like.
Yeah, and I'll add to Anthony's response about what the Congress can do. I've seen some really positive things come out of the Trump administration in terms of 340B. So in the president's budget, they had a proposal in for 340B, and one of the things that it said in the budget was that 340B is considered a condition of participation in the Medicaid program, which I thought was just such an excellent, nice statement in the president's budget. And it signals that this administration, especially the Centers for Medicare and Medicaid Services, is more globally thinking about how conditions of participation can be used as a tool within the healthcare system. So in order to be providing services in either Medicare or Medicaid, most types of providers are subject to a set of rules and regulations that they have to be able to demonstrate that they can do to treat patients in those programs. There's a whole set of hospital conditions of participation, and it's a great way this administration can sort of move forward to enforce new changes in the 340B program. So for example, if hospitals are not reporting enough transparency about where the money flows that they're making off of the 340B program, the Centers for Medicare and Medicaid Services could make that a condition of participation in participating in Medicare and Medicaid. So it's very positive, forward-thinking things that this administration is taking on that's new and unique that we really haven't seen in the past in management of some of these programs.
So you mentioned transparency. You and I have talked about the Medicare Plan Finder for a really long time. In fact, I'm actually a little tired of talking about it because no one seems to want to improve it, yet in other markets, you are able to search for your plan and search for your doctor, see if they're a network, and drugs too. So what do you think CMS should do, and are there things you think that we should do to fix the Medicare enrollment process, make it easier? And I say this because I have friends who are older and they get the Medicare handbook and it shows up, it's over 100 pages and it's not very clear and they get confused.
Yeah, I think it's a great question, and it's a really important question since we know we have about 10,000 baby boomers a day who are becoming eligible for the Medicare program, so they have to make a decision about how they will be covered by the program. So they can choose to use their sort of traditional route where they work to manage a lot of the care that they receive themselves, or they can opt to choose what's called the Medicare Advantage plan or a private insurance entity to help them manage their benefits. And that's a hard decision for some beneficiaries to make. There's a lot that goes into it. There are pros and cons to choosing one option versus the other. And one of the ways that I think the Medicare program can look at making that decision user-friendly for people is to allow them the functionality to ask for what best suits their personal needs. So imagine a system that we had in place, and let's say, for example, you're a dually eligible beneficiary. So you are eligible for both Medicare and Medicaid. When you are in that special circumstance of 12 million Americans, you should be able to input that information into a plan finder and then receive information back that is tailored to you and your specific needs as a patient. We don't have all of those resources in place today, but I'm very hopeful, especially, I think I was on Twitter today, CMS Administrator Dr. Oz just recently turned 65. And so some of these issues are really relevant to him on his mind. He's talking about the resources that we have, the Medicare handbook, you can call the 1-800-Medicare line, and trying to build in more capacity in the agency to empower people to customize what they need out of the Medicare program moving forward. We have a lot of improvements to make, but I think we have the right team in place to start to embrace those things.
I hope that he tweets about his enrollment experience. That would actually be pretty interesting. So former Deputy Secretary Hark and I have long talked about the CDC, and he and I didn't get a chance to get into it and discuss this specific area, but he talks about it as the fire station of public health. Right? It has things it has to do, it's there, it responds to emergencies, maybe there's an ambulance component to it too, not just the fire trucks. But I'm curious, Neeraj, do you agree with that statement? And if so, how can the administration and policymakers in Congress reform the CDC to better support states and localities?
Yeah, that's a great question. I think that analogy is very telling in terms of kind of what people view the role of the CDC is, right? When people think of fire stations or emergency medical services, things like that, they think of kind of the response part to an emergency, but there's also the preparedness element that people have in these institutions and also should have within the CDC. I think, we are about 5 years out from kind of one of the largest public health crises that this nation faced over the last century, really. And there are critiques from both sides of the aisle that says that CDC kind of did not meet expectations. I think if you're looking at where to go in terms of reform, you can kind of really focus on three things. One, CDC and CDC leaders and advocates for the CDC would like to say that, the budget of the CDC previously has been anywhere between the range of $6 and $9 billion. 80% of that money tends to go out to state and local territorial health departments. My kind of counterpoint to that would be, well, if 80% of your budget is going out, why are 90% of your staff based in Atlanta? There's some element of decentralization that needs to happen to the CDC in order to best support the public health apparatus, not just in the response by providing technical expertise on the grounds, but then also in the preparedness by helping local health departments, who are really the frontline workers in public health, better achieve their mission and provide technical guidance and assistance.
So, we both worked clinically during the pandemic, and I remember many years ago, seems like it was yesterday, but was many years ago, when I was in medical school, I rotated through a local public health department in Jacksonville, Florida, Duval County, and the people were like the salt of the earth, right? Good people trying to get stuff done. But when they needed money, right, it came from the locality or the state, but a lot of it came from the CDC. It was a centralized command and control infrastructure for funding, and it was sort of what I call Mother May I. Mm-hmm. Like the department would have to go to the CDC to get grants, and so they'd have to meet the needs of those in Atlanta to determine what's happening in Duval County in Florida. The same thing's happening in Nebraska, Nevada, California. Do you think that the administration and Congress should strive to return some of those public health functions, and in particular, the financing to maybe governors and localities, rather than insisting that local and state health departments essentially bow to Atlanta in order to get their basic funding?
Yeah, I think that's a great point, right? The problems that are faced in Washington, D.C. are much different than the problems that are faced in Greensboro, North Carolina, or much problems that are faced in rural counties in Arizona or South Dakota. And I think when we conceptualize public health as a local issue, meaning that the local public health departments and the state and local territorial health entities are the ones that are the frontline workers and the ones facing the crises, it's a little bit counterintuitive to say that your funding is going to be dependent on whatever programs are currently going on at the federal level, primarily the CDC. I think there are going to be proponents that don't necessarily support this, but there are already large buckets of money that are already going out to state and local territorial health entities in the forms of FAP or ELC, and moving more towards a model that provides a little bit of flexibility, potentially in the form of block grants, to these state and local territorial health entities would allow them the flexibility to deal with the challenges that they face on the ground, rather than kind of limiting buckets of money to one particular niche purpose.
Right, because San Francisco may want to spend money differently than Houston, and that's okay within limited confines. Lisa, MedPAC. I'm on MedPAC. You worked for the Committee of Jurisdiction in the House. Obviously, our views are our own. You've been doing a lot of work on comparing fee-for-service Medicare and Medicare Advantage. Can you share some thoughts on the MedPAC analysis, the AHIP analysis, other analyses are there that are out there, and what the right methodology or methodologies are? Because there's a lot of debate right now and lots of different answers to what we would think is a simple question, but actually isn't.
Yeah, thanks for that question, Brian. And MedPAC is the Medicare Payment Advisory Commission. It's an advisory board that gives recommendations to the US Congress when they're contemplating policy changes. And MedPAC has a way of measuring changes between the traditional Medicare, part of the Medicare program, and Medicare Advantage. And then there's really sort of, I would say, a lack of consensus across how to compare those two different parts of the Medicare program. What MedPAC specifically has focused on is the amount of taxpayer dollars that go to support one part of the program versus the other. They're somewhere in the range of above 100%, maybe up to as much as 122% goes towards Medicare Advantage. And if there's a difference between the traditional part, that's where policymakers come in and have a debate as to whether or not that difference or a pay gap between those are justified. So are we as American taxpayers getting value out of the program that we need to see? And Brian's question goes to what is the appropriate population to be comparing between those two parts of the Medicare program? Do you concentrate on people who choose fee-for-service? Do you concentrate on people who choose Medicare Advantage? There's a third population of people who switch between fee-for-service and Medicare Advantage. Do you use them as the example because they are making choices between both parts of it? I think there's a lot of debate out there. It seems that some consensus, at least with the Trump administration, may be leaning a little bit towards we should use the Medicare Advantage population to look at to measure the value that we get out of that. So the Trump administration has recently announced that they're going to be auditing to a large extent, to a much greater extent than previous administrations have, the Medicare Advantage program. So they will be taking in individual medical records to audit towards what Medicare Advantage plans are actually delivering in care. And that may mean that there's going to be changes coming depending on what they find within those audits. I think that's a very healthy thing for the Medicare program. That's exactly the role that the agency should be playing. We have to monitor all parts of the Medicare program to make sure that we can promise beneficiaries the benefits that we want to give them for the life of the Medicare program. So it's a good thing that they're concentrating on those, and it's probably premature to do a lot of policy specifically in Medicare Advantage at this time, while the agency takes its time to really study this issue and make recommendations. But any other body, including the US Congress, who makes policy changes at this time, it may be pretty premature to do that.
I think that's a fair point. And I think the thing that's interesting is you mentioned people who are choosing MA or choosing fee-for-service. Those are fundamentally different health insurance benefit designs. If you're lower income or middle income and you're retired and you don't have many assets, functionally the only affordable way to get Medigap coverage and Part D coverage is choosing MA, and you just hope that you have enough assets and you get the PPO and not the HMO plan. And I joke with my wife that our goal, our financial goal for retirement is to get the MA PPO plan, because fee-for-service and Medicare supplemental plans are going to be so unaffordable by the time we all retire. I think the other thing that's interesting about that, and I'm curious if you could comment on looking at those who switch or those who stick versus also with whatever their program is in terms of MA versus fee-for-service, or as others have posited, whether the right answer is to look at what people choose when they enroll in the program, or do you think it's all of these need to be examined to come up with a holistic answer?
Yeah, I certainly think it's all of those different options. We really want to make sure that we are letting the choices that beneficiaries make influence the way that we look at how these choices are made in the Medicare program. And people either choose to stay with fee-for-service, stay with Medicare Advantage, or switch. Those are all important choices and choices that we should respect and therefore study all of them.
Right, and study it not just when they switch when they're in the program or stay, but also what their initial enrollment choice is too.
Yep.
And so a question for you, Anthony. We have the reconciliation bill going on. I know you've written about Medicaid work requirements in the past. Much has been made about this. I've seen a lot of noise in the news. Can you spend a few minutes outlining sort of Medicaid work requirements as proposed and what your thoughts are and what the real world impacts look like?
Sure, thanks. You were just talking to Deputy Secretary Hargan about social determinants of health. We all know as practicing physicians that people that are in the workforce just have better outcomes. So work is a social determinant of health. Being in the workforce improves your health outcomes. The work requirements, I think, are an incentive to get people into the workforce. I don't look at them as a punitive measure as much as an incentive measure to get people working. So the work requirements that are in the reconciliation package are fairly benign, 80 hours a month of work, community service, job training, or education. It is only for a subset of Medicaid beneficiaries, so it's not targeted at anyone with a disability, anyone who's a caregiver, anyone who's elderly. It's for the able-bodied poor who have the ability to work. And what we hope that this will do is get, again, like you said, get people back into the workforce and tackle that social determinant of health. Very great piece was just released by one of your colleagues here, Kevin Corinth, on what the working-aged Medicaid beneficiaries do with their time day to day. And they found about 125 hours a month are spent watching television and playing video games. Those people are just not going to have the same health outcomes as if they were out in the workforce, doing community service, getting out of the house. So I think this is a great way to incentivize people to get into the workforce, to have that social determinant of health, and hopefully make the overall patient population healthier and transition them into stable employment.
And does this remind you of sort of welfare reform from the 90s?
Yeah, exactly. We have a work requirement in TANF, and there actually is good data that that TANF work requirement did increase employment amongst beneficiaries. It led to higher overall earnings in that beneficiary group. So I think this is a great example of how that can work. This has never been tried at a national scale, so people will bring up prior smaller work requirement experiments that have been done. I don't think those are really applicable because it's never really been tried at a large scale. The work requirement makes the onus really on the states to make sure that these requirements are met. And so I think states are going to take that extra step to make sure that their beneficiaries are actually meeting the requirement, and it's going to make them healthier overall.
So you don't think, to be clear, you don't support child labor. You don't support a work requirement, and the bill doesn't have a work requirement for disabled beneficiaries in Medicaid, and it doesn't require that pregnant women on Medicaid work.
That's correct. Again, the exemptions are pretty generous, and I agree with them, and including, again, caregivers. If you're a caregiver of a disabled person, then you are exempt from the work requirement. So it's a pretty lenient work requirement. I think it's pretty compassionate, and again, I look at this as an incentive for better health, not as a punitive measure.
Sounds pretty practical.
I agree.
So I want to turn to chronic disease. Lots of challenges. I know, Neeraj, that the CDC has spent billions of dollars combating obesity, diabetes, and hypertension over the past 20 or 30 years. I think we can agree that that probably hasn't worked.
I think that's a fair statement. I think if the point of the CDC is to be all things to everyone, it's just never going to be, right? I think the idea that CDC, as the definition of public health expands, as the essential services of public health expands, the CDC was going to expand its mission to hit all of those things and do them all well. That was a pipe dream, right? I think these are certainly important factors. Chronic disease is one of the major killers in the United States. It's one of the major economic burdens in the United States. The expectation that the CDC be good at fighting hypertension, good at fighting cardiovascular disease, but then also be able to function efficiently during a pandemic, that's just an unrealistic expectation. There are kind of some changes going on and some changes proposed about moving some of those divisions outside of the CDC to other agencies within HHS that may be better homes. I think the only thing that will kind of inform us this time as far as the efficacy of those changes.
I was going to say, can you comment on the recent budget proposal for the CDC and also the Administration for a Healthy America?
Yeah, I think full disclosure, 670 pages is hard to read in a little bit of time, but I've looked into it a decent amount, and there are essentially the proposal for CDC would aim to eliminate things like NIOSH, things like the National Center for Environmental Health, and chronic disease and preventative services, and transition some of those programs to the Agency for a Healthy America. This kind of nihilistic view that, oh, those programs are going to be gone, and the funding that state and local territorial health departments kind of rely upon to implement some of these programs in their locales is therefore also going to be gone, I think is a little bit premature. These are all still very dynamic changes that are happening, and we don't know what the final product is going to look like. But I do think that there is an emphasis on chronic disease that still exists. It's just different than the ones that we've seen for the last 20 years.
Right, and if the CDC has been unable to be successful at that mission with billions of dollars, it's not unreasonable to try either a new organization, a new policy leveler, a new program, or just a new way of thinking.
Yeah, I think there's definitely some potential opportunities for new synergies and new ideas to come out of rehousing some of these institutions or some of these programs into newer institutions.
So thinking about the Overton window and thinking about things that are broken, that list is very long in health policy, so I probably shouldn't have said that. Fee-for-service Medicare and long-term care has not worked very well. Lisa, what do you think can be done over the next couple of years to sort of improve long-term care? Because I remember I got that question from a Senate staffer several years ago while I was having coffee, and I immediately started sweating. And it wasn't even warm out because I didn't have an answer, because it's a very, very hard problem.
Yeah, so one of the things, just to piggyback off of something that Anthony mentioned, was the work requirements have an exemption for people who are providing direct care to disabled beneficiaries. So that's a very practical policy change that hopefully will be coming and signed into law very soon. And that's one great way to expand the workforce. So that's one sort of practical answer in ways that this administration and the US Congress has sort of looked at the issue. Specifically to fee-for-service Medicare, it's pretty fragmented. Getting post-acute care, there are 4 different unique settings of care within Medicare. It's about $60 billion in annual spending, so it's a lot of money that goes into it as well, but it's hard sometimes for beneficiaries, and the 2 physicians on the panel may say sometimes for three physicians
Thank you very much.
on the panel today that can sort of attest to that sometimes it's difficult to find a place to discharge beneficiaries to that are most appropriate for the medical care that they need. So there's competition between the most complex severity part of the patient care, which is called long-term care hospitals, and then there's rehab needs. Some of the patients that Anthony treats, specifically for spinal cord injuries, may be most appropriate for that setting of care, but those also compete with skilled nursing facilities. And then there's beneficiary choice around wanting to get their post-acute care at home. So home health competes with all of those as well. And it's been hard for the Medicare program to sort of make recommendations and put incentives in place to help clinicians and beneficiaries make, and their caregiving team, really make those decisions. So one way that the US Congress can look at making improvements in those areas are in a policy area that I call sort of unifying payment across all of those and creating a site neutrality across all of them. So reimbursement can flow where those different sets of providers can most appropriately treat and get the best outcomes for those patients. That's not the system, unfortunately, that we have in place today, but it is an area that really, there's been a lot of work done by the Centers for Medicare and Medicaid Services. It's been supported by the US Congress, and it really just takes the desire to step up to the policy plate and actually move forward with those types of incentives. I think we're ready for those types of things right now.
I would probably have a slightly different answer than you on that, as you can expect, because I have a view of the post-acute care space, which is different. But turning to just straight up fee-for-service Medicare, what would you do, and Anthony, also a question for you, if you could do one thing to improve fee-for-service Medicare? Anthony, you've talked a lot about prior authorization. Lisa, you and I have talked about the physician fee schedule. I'd welcome your thoughts.
I mean, if you're talking about Medicare fee-for-service, just in
Well,
general.
prior authorization in general in Medicare Advantage, in the ESI market, in Medicaid markets, what do you think the problem is? And then separately, how would you improve the Medicare fee-for-service program?
I think prior authorization it's an unfortunate necessity in our healthcare system. And what I mean by that is that most physicians hate prior auth, right? We don't like having our judgment questioned, which is essentially what it is. But it is necessary. And I think if physicians are going to get to a place where we have a larger ownership stake in the healthcare delivery ecosystem, if there's Stark Law reform, if we repeal the ban on physician-owned hospitals, et cetera, we're going to have to accept that utilization control is necessary. And I think we should be happy to get to that point. I think there's a lot of process improvements you could have in utilization control and prior authorization. I think a lot of it can be automated. A lot of it can reward efficiency. Certainly in a more competitive healthcare marketplace, efficiencies would be rewarded. So in terms of prior authorization, I think that physicians need to stop with the conversation leading off with prior authorization is bad, never question anything I order, to we accept prior authorization as a necessary evil in the system, and here's how we're going to smooth out the process and improve efficiency.
And you mentioned Stark Law and physician-owned hospitals. Do you think that there is any hope of that changing?
Yes, I think there's a lot of hope. I think that there's a groundswell. I think repeal of Section 6001 of the ACA, the ban on physician-owned hospitals, I think is paramount to reintroducing a lot of competition in the healthcare system. If you mentioned one thing I could fix within Medicare, it would be that, is fixing the ban on physician-owned hospitals. Because again, if physicians have more ownership stake in the delivery of the healthcare, in the ecosystem, then all these other little battles, the physician fee schedule, these aren't going to matter as much because we are owning the means of production, so to speak. There's plenty of data showing that physician-owned hospitals, independent physician clinics have better outcomes, lower cost, higher patient satisfaction, higher clinician satisfaction. Certainly in neurosurgery, there's some very successful physician-owned hospitals and physician-owned ASCs that have higher quality and lower cost than large hospital competitors.
I heard own the means of production and was very surprised as a supporter of private enterprise. So you think that ownership would trump a change to the physician fee schedule 7 days a week?
Absolutely, 100%.
Lisa?
Yeah, I certainly agree with Anthony on that assessment. And one of the things, maybe if I can be critical to the physician profession, as they've seemed to sometimes favor fee-for-service Medicare for issues like Anthony just highlighted because of prior authorization in Medicare Advantage, there's not a lot of prior authorization on the fee-for-service side. There is a lot of natural autonomy, but I do think that that's a ripe area for reform as well. So one of the things I've heard Secretary Kennedy talk about more recently is looking at how codes are used within the Medicare physician fee schedule on the fee-for-service side, and possibly disrupting the way that the American Medical Association uses CPT coding and what they have over that. I think that's a very healthy reform for this administration to be considering. And coming into a reconciliation bill, I was kind of surprised that the House bill had a fix for Medicare physician payment in it, when the president has been very vocal about Medicare not being a program that was going to be targeted in reconciliation. That has now sort of opened the door to a new entitlement because of a specific physician ask. And if we can't get out of that cycle, it may just be looked at the Medicare sort of program to pay for these types of things in the Medicare program, and actually looking at CPT and some of the incentives around that may get us out of this perpetual cycle and into more capitated-based payment reforms like Medicare Advantage can offer in the program.
Can I, real quick, piggyback on that? When you say that there's no prior auth in fee-for-service, that's absolutely correct. But there's a ton of things that doctors hate in fee-for-service that we don't necessarily associate with that. Number one being quality metrics. The MIP system, teams, all these sort of things that come out that mandate physicians spend a lot of time and effort on quality metrics, on documenting. This all comes out of fee-for-service. Those aren't necessary in a system that has other means of utilization management. Fee-for-service doesn't have the natural utilization management, and therefore we have to do all these things like quality metrics to maintain the utilization management in the fee-for-service side. And I think a lot of physicians sort of miss that point.
Okay, well, I want to allow for a few minutes from questions from the audience. We'll have wandering mics, and I'll also look at our online if we have any questions. 1 second. Yes, we have a question over there.
Hi. You've talked about the CDC working as kind of a firehouse, where the visible aspect is the response, but preparation is just as, if not more important. How do you reconcile that priority with then what is seems to be kind of a rescinding of university grants and the current administration's approach to funding research in the medical field?
Yeah, that's a great question. I think the question is, I'd like to narrow it down in terms of like, what do you think of as prevention? Yes, there certainly is the academic research side of things that kind of tests out new, whether it's medications or kind of public health interventions, but then there's the actual practice of public health. I think it kind of goes back to 90% of the CDC workforce being based out of Atlanta and not necessarily being well poised to support state and local territorial health agencies. I think if you were to restructure the CDC in a way into where it's less centralized in Atlanta and potentially structure those specialists at state levels so that there's quicker liaisons and quicker points of contacts between state and local territorial health leaders and the CDC, there can be a little bit better prevention or surveillance or observation so that we can early identify threats and then potentially intervene on them earlier. There's without a doubt kind of a question mark in the air right now as far as the status of academic funding and as the status of research funding going forward. But I do think that that's only one aspect of it. We do have existing funds to carry out public health interventions, and if we kind of focus more on the academia, then we lose track of kind of the people on the front lines doing the actual work.
So I have a question from online. I think this is probably best for Lisa. The question was, what about Medicare Advantage special needs plans? Do you see any regulatory policy opportunities for improvement for that marketplace? And I know what special needs plans are. Maybe you could also spend a minute for the audience explaining what they are.
Sure, thanks, and thank you for the question. Special needs plans, there's 3 different types of special needs plans within Medicare Advantage that different beneficiaries can qualify for. The first is called a D special needs plan, or a D-SNP. That's geared towards people who are dually eligible, so they have both Medicare and Medicaid. There's an I-SNP, so the I stands for institution. Those are beneficiaries that live in a nursing home and receive all of their care from the nursing home. And then the third category is C-SNPs, or chronic special needs plans for people who have multiple chronic conditions. So those are the 3 different options. And I think there's a lot of opportunity from the perspective of the executive branch to have some of those programs communicate with each other. So we should be able to put in place incentives that if you are at the point in your trajectory in the Medicare program and you're in a D-SNP or you're dually eligible, you may be a younger beneficiary who's still fully active. But if you're dually eligible and towards the end of your life cycle in the Medicare program, you may need more specialized help and could transition to an I-SNP. 92% of Medicare beneficiaries who are in an I-SNP program are also dually eligible. If we could put in place incentives to have those 2 aspects of the Medicare program within Medicare Advantage talk to each other and smooth the transition across those, that's a great way that this administration could actually enable people to maintain choice and smooth across those different programs. So putting incentives in place to do those kinds of things amongst the many different options in Medicare are what policymakers should be considering.
I mean, the other thing I would add, which when I found out, it sort of blew my mind, is that special needs plans don't have any specialized regulations, right? So you have a specialized benefits package for someone who's dual eligible or has a chronic disease like heart failure with reduced EF, or lives in a long-term care facility, a skilled nursing facility, and that has, for example, the same network adequacy requirements for the beneficiary who can't put on a sweater and feed themselves as the tennis-playing 75-year-old in Southwest Phoenix who's enrolled in a chronic disease special needs plan to manage their diabetes. So I think there's a lot of things that the administration can do to promote specialized regulations, to promote personalized and customized care.
Yeah, certainly this administration has a stated goal of deregulation, and this is a space exactly where we could use some more specialized deregulation to really let these models proliferate and increase choice for beneficiaries.
Other questions?
This is a practical question. I'm a practical person. I was a little late, so I didn't hear how everybody stood exactly on the Medicare changes or Medicaid changes. But what would, if you're going to vote for it, what should the response be to the millions of people who will lose their coverage through no fault of their own, other than increased levels of paperwork, who seemingly don't fall into a, quote, waste, fraud, or abuse category? They're not going to have access to health care now. How does that improve our public health? Thanks.
So I think that to save the amount we saved in Medicaid without a benefit cut is, I think, a huge victory. I don't foresee a lot of people losing their coverage because of this. I think a lot of it is about eligibility tightening. A lot of it is about verifying people aren't enrolled in duplicate states or they don't have private insurance coverage as well. So I don't agree with a lot of the numbers that are as catastrophic as they are about the coverage losses. And I think it's fortunate that we're able to keep the whole benefits package in addition to making the Medicaid program leaner and more targeted towards the beneficiaries that it was meant to help.
I would also add that the CBO has a poor history of accurately projecting health enrollment and costs, whether it's the cost of the Medicare Part D program, which I believe the CBO was off by, if my memory calls me, is correct, 100%. The ACA exchange enrollment, the cost, it was projected as a savings, but actually became a coster for CMMI. So the CBO's projection in the health policy space, I think, could use some improvement. So when I see those numbers, I remain concerned both about their accuracy and also the precision of those estimates. I don't think anyone up here wants anyone to lose their health coverage. I think that, three of us are physicians, right? We recognize that Medicaid is an important part of the fabric of society. Right, there are many of my patients who, if they didn't have Medicaid, they wouldn't have health coverage. I don't think any of us want to take anyone's Medicaid away, because that would affect what we do in our time when we're not sitting up here on the panel.
But they will. That's the point.
I think what we're saying,
will lose coverage, whether it's $1 million or $10 million, they will lose it.
I think what we're saying is that there's room for debate on that, and that there are probably people who qualify for other programs like the ACA exchange, for example.
I agree.
Other questions?
Hello? 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 Okay. Given the discussion around prior authorization and looking and thinking through some of the regulations that came out under the HTI 2 rule and the kind of proposed and floated HTI 3 rule around prior authorization and that integration into EHRs, do we believe that the administration would be amenable or encouraged, or would you all encourage the administration to look at the integration of prior authorization to support the ongoing collection and improvement of quality, as well as the utilization controls that you all are speaking of?
Sorry, can you clarify a little bit?
Sure. So there were regulations that came out around the integration of prior authorization essentially into EHRs for physicians. These are regulations that are supposed to be going into requirements that would be going into effect in 2027. Just wondering if you all would encourage the administration to continue and keep those regulations in place, pushing on that prior authorization. And would you also support that given the use of quality measurement and quality in the quality ecosystem across physicians, fee-for-service, so forth and so on?
I'm always skeptical of interventions that propose to legislate efficiencies. I think, again, if we have a more competitive ecosystem, that would let these efficiencies come through naturally. I think that the way prior authorization is handled often, both of the provider side and the plan side, is there's a lot of opacity. A lot of the prior auths are simply because things are coded incorrectly, or the wrong length of stay was selected, et cetera. And so I don't know that really mandating those in the EHR is going to smooth that process a whole lot. I think the goalposts are going to shift, and so I'm less optimistic that mandating in the EHR is going to help. In terms of automating quality metrics, I think that there's a huge amount that can be done with that, especially with LLMs and AI, and I would love to see more automation in quality metrics. The way that we record quality metrics now is awfully Byzantine and antiquated, and so I think that there's a lot that we could do in AHR to automate quality metric, especially with the LLMs.
I also have some thoughts on prior authorization. I joke that we've all been subject to, or at least 3 of us have been subject to prior authorization as physicians, and we all probably have been subject to prior authorization as patients, I imagine, at some point or another. So I think we all admit that physicians sometimes order things that maybe don't make sense, but frequently physicians do know what they're doing, and so that third party is sort of looking over us, and that third party looking over us when it's a fax machine or a PDF or paper, I think we can all agree that that's objectively stupid, right? Like at my house recently, I received some prior authorization paperwork, and how'd you find my home address, and why am I getting this thick envelope, right? So that's confusing to me. Without knowing the specifics, recalling the specifics of that rule, I think pushing it to the point of service is helpful, whether that point of service is the pharmacy counter, the exam room, and sort of automating that component of data submission, and making it like it should be easy. You can click a button, it sends the MRI and your clinical note. Now, that's something that EHR manufacturers, hospitals, and the managed care industry need to get in front of and solve that operational problem. A reg may or may not do that. There have been lots of proposed regs over 25 years about prior auth, most of which I don't think have worked. Doesn't mean that that one would or would not work, rather that everyone needs to get together and solve that problem, because it's ridiculous that that's a pretty manual process. I would also add, so in addition to solving that manual process, there's a problem on the physician side, where our documentation is often objectively terrible, right? So if you're a managed care company and the patient's been admitted to the hospital and the progress note has been copy forwarded for the last 7 days with no changes, like you as the manager, and also you got sent the copy forwarded progress notes from another patient on the floor, the wrong patient, right? Like it's no surprise then that the prior authorization for the extension of the hospital stay is denied, right? And as I said, 3 of us practice, and we know that the degree of copy forwarding and just poor documentation that's incomplete is at least probably, very conservatively, a third of clinicians. But partially that's because the systems aren't user-friendly, and I think with the advent of voice dictation and also sort of ambient AI to improve documentation, over the next 5 years, that will probably reduce a lot of friction.
I think when I think of putting EHR prior auth into EHR, I think of when Congress, the CMS tried to institute the appropriate use criteria for imaging orders. I ordered a ton of imaging as a neurosurgeon, and every time I ordered a CT or MRI, a box would pop up and would say, the ICD code you selected is incorrect. Even though I had a huge note dictating why this patient with a brain tumor needed an MRI, it would still stop me, and I had to select from a list of ICD-10 codes, and it gave me the list, so I just added extra 4 or 5 clicks that I had to go and select the right ICD-10 code, and so it was very clunky, and I think that you're absolutely right. With AI, with LLMs, we could probably smooth that process a whole bunch.
All right, because your skill as a neurosurgeon is best used checking boxes.
Absolutely. The more time I can spend checking boxes and less time in the OR, it benefits everybody.
I mean, as the internist desk jockey, who am I to talk? Well, with that, thank you all for joining us. We're going to break for cocktail hour.
Thank you, Brian.